Welcome everyone to the session that one size doesn't fit all for your virtual care journey. And feel free to, get up and get your breakfast and while we get started, because we have a lot to cover and we want to make sure we have plenty of time. So thank you all for getting up so early and joining us this morning. When we looked at this, we were just talking this morning, this is almost like the nursing process. If this is back to basics, like we know this. We know how to do quality improvement and we know how to implement things. So if you just think about virtual care, like there's a problem, there's an intervention, and there are outcomes. And that's kind of the format of how we're going to talk through how these very different patients from different, we often accidentally call our customers our patients at Avasure because we have so many nurses. And we want to be nurses. So anyways, the different health systems have different challenges and approach the virtual care journey from different ways based on that. I do want to say one additional thing, that it's not just solving problems. Solving a problem is important, but you also, as you're approaching your virtual care maturity, you also want to ask yourself this really important question: what opportunities do I want to set myself up for in the next 3 to 5 years as well? So it's kind of like a positive aspirational goal, as well as a very practical, maybe more near term, we have some issues we need to solve. So we have those placemats there because we knew last year we did this and there were like questions and we went over on the time, and so we want to make sure you kind of have everyone's background right in front of you, and also hope that you'll find an organization that you relate to. So really listen for the similarities to you and your organization rather than the differences, like, oh, that doesn't apply to me. So let's get started just with kind of our setting the stage. So I'll start with you, Brenda. If you can just talk about a little bit about your role in your organization and what prompted you to embark on this journey, virtual care journey.
So my name is Brenda Gallardo. I'm the interim chief nursing officer for a large public county hospital in Los Angeles County. We are a level 1 trauma center. We have about 650 beds. Embedded within our beds, we have a jail complex. We have a very large emergency room. We have inpatient psychiatric services and a very underserved patient population. We decided to embark on this journey really for throughput. That was our original idea behind establishing a discharge waiting unit, and then on top of that, including our virtual nursing for discharges.
Okay. Yes. Go ahead. I just want to say, when we visited your organization, it was such a happy place. There were food trucks and therapeutic clowns that we ran into. I just love the culture that you've set there, and I also want to mention you're the first.
We are the first county hospital to have received magnet designation, which we achieved. I do want to give a shout out. I see a few of my directors and nurse managers out there, so thank you for supporting us, and they are really the reason that we have achieved so much.
Awesome. Go ahead, Amber.
I'm Amber Bond. I am a director of one of our med-surg units at Peterson Health and our clinical decision unit. And we are a small rural hospital. We're 124 beds. We have our telesitter program is used in the med-surg units. We have an acute rehab unit that we use it. We use them in our emergency department, sometimes in women's services, so really throughout the hospital. I think we initially approached looking at telesitter because we were trying to improve quality outcomes such as falls and fall prevention, but have just really taken that to the next level and use it in multiple other ways.
And then what prompted you to layer AI onto your virtual sitting?
I think that we were pretty pretty much maxed out daily with the use of our cameras. And we had a few falls with patients that were on Telesitter. And so the AI program can help them. We have a geriatric population. So it's not just falls that we're worried about. A lot of times, they're confused, all kinds of different reasons. And so we really wanted to give them another tool to help guide them to, when they're voiced into this room, this light's going off saying, hey, look over here. And so they're easily able to kind of move their,
Awesome. Thank you. And Brenda and Marie, why don't we start with, I'm sorry, Ramanita. Why don't we start with you about your organization and kind of your impetus to get started?
So I'm Ramanita Jimenez, the Chief Nursing Officer at Hackensack University Medical Center, a large academic medical center in New Jersey. We also do a lot of research. We're 803 beds, level 1 trauma center. We have a children's hospital, a women's hospital, and we also, sure, absolutely. We also have, we're the second hospital in the nation to become a magnet, right? So thank you. And we are 7th time designation, working on our 8th now, a lot of great stuff. And virtual nursing, why virtual nursing? Throughput was part of it. Also, our issues with falls as well. So we do the telesitters with Avashore as well as the virtual nursing. So Marie actually will be speaking about, she's further along in the journey than we are, but we've been able to see some really great, our metrics have changed in a really good way. So we'll be able to share some of that with you regarding virtual nursing and its impact. We also have a very novice workforce. There are units that I have that 60% of the workforce is nurses under 3 years of experience. So that is our reality, and that's what we're working with. So anything that we can do to support our novice workforce, we want to do.
Good morning, everyone. I'm Marie Foley-Danaker. I'm the chief nurse at Ocean University Medical Center, which is with Hackensack Meridian Health. My campus is 357 beds, predominantly geriatric. We are the retirement area for the New York metro area, so really high-dense senior population. When we got into virtual nursing, we had been partners with Avashore for many years for Telesitter. So when we went out to look for who we would partner with for virtual nursing, Avashore was it just made sense, right? We knew the quality of the product, and we knew we could build a model from it. Looking at what our model is going to be, where I come to this as the chief nurse at Ocean, be careful what you wish for, because it's other duties as assigned. So when the CNE called, she's like, listen, I really want to explore this virtual nursing thing. And I was like, okay, great, sure. Didn't really know what I was signing on for. But here we are 5 years later, and I can't believe where we, where we envisioned where we started to where we are today, really. We came into this, in the throes of the pandemic, nurses leaving the workforce, and looking to really reevaluate our clinical outcomes and our team outcomes. And where we found this real opportunity was to give nurses the chance to be nurses. So much of our time is spent working on the WOW, the computer, and not enough face-to-face time with patients. And we saw an opportunity to, those high throughput units, decrease the administrative burden for our nurses so that they would find more value in care, and we would see the quality metrics too of increasing throughput and decreasing length of stay.
Do you want to talk a little bit about your model and how you staff it? Because that's a little bit different, and Brenda can share how theirs is a different
Sure,
model.
happy to.
Yeah.
We have chosen, again, if the goal is for us to keep the nurse at the bedside, we need to support those novice nurses in the workforce. In HMH, if we were trying to build this in-house, our most senior nurse would probably be the first ones to apply for these positions, and we'd brain drain the bedside even worse. We want to support those nurses so they want to stay at the bedside. So we chose to partner with a company called Equum out of Tennessee. And they're all experienced nurses. Most have a critical care background, actually all have a critical care background. And they provide the virtual nursing service in partnership with our bedside nurses from Tennessee. And it's been a win-win.
Yeah, and you do it differently. So how, in your model, Yeah.
So we staff our virtual nurses for discharges and admissions with our discharge waiting nurses. So we have an entire department of about 18 nurses with varied backgrounds. Some have pediatric backgrounds, some have med-surg background, critical care background, and those are the nurses that we assign to virtual care as part of their day-to-day assignments. So we keep it in-house.
Yeah. And then one other newer modality that you've added is your hospitalist rounding, the boost rounding. So, yeah.
Sorry, I'm going to steal it again.
Sure.
Oh, sorry. So one of our hospitals, we're beyond pilot, but one of our 4 hospitals has chosen to implement, I mean, we have the technology, let's maximize the utilization of it. Adding the hospitalists, they do morning MDRs with the clinical team at the bedside, but we're piloting coming back for a second round in the afternoon where the hospitalist can follow up with the patient and give them an update as to their plan of care. So Jersey Shore is a very large campus, much like a little smaller than HUMC, but getting that hospitalist back and forth across the building, they're choosing to leverage the camera technology that we have in place, and they're coming on and updating the patient virtually from another area of the building, and they're getting through those rounds quickly in the afternoon, so it's not as big a pain point for the hospitalist. They're really excited about it, and we're gonna see what the metrics are soon from the program. Looking forward to it.
Yeah. We love this picture here. Right in the middle is the sitting down is the Avashore nurse, Nick Culver, and he's an ER nurse, and he loves being an educator. So, and it's just kind of fun to see him with the hospitalist there. And that was just maybe about a month ago. So,
Yep.
Come back again next year and tell us how the outcomes on that one. All right. And I think we probably, who all has seen a presentation on virtual nursing? Everyone. Okay. So we didn't want to kind of go through and say, this is the role of the virtual nurse with the Venn diagram of what the bedside nurse does, and we're focusing on admissions and discharges. I mean, because that's kind of like, okay, we've heard that. And those are the kind of what we're focusing on is length of stay for both. So, but what we really wanted to cut to the chase here and get to what the outcomes are and then lessons learned, and maybe we'll have time for questions. Kind of moving back to you, Brenda, at LA General, you've had some great outcomes on throughput as well as patient experience. So maybe you can kind of walk us through your outcomes on throughput first.
So first, I think one of the key things we did was really put our both our bed assigned to bed occupy and our discharge turnaround time on each unit's balance scorecard. So we've developed accountability care units for each one of our actual inpatient areas, and so our triads are really looking at these numbers month to month. We also incorporated the use of our discharge waiting unit and utilization of that onto their balance scorecards, as well as virtual nursing in those spaces where we can for admissions, which we have limited our virtual nursing admissions to our medical surgical areas and our telemetry unit. And so what we found was in partnership with the emergency department and that team to really look at how we built trust and how we move forward with still pushing patients out. We have not gotten to the point where we can really pull them, but the ER is really helping us get them upstairs. And so with the incorporation of our virtual nursing program, we were able to see both a decrease in our bed assigned to bed occupy, as well as our discharge turnaround times. And I do want to mention the patients really do have a lot of other social needs. And so the need for a ride home, the need for medication education, the need for support services, social work, all of that was really a factor that we took into account when we started looking at discharge and how we can support the patient sometimes in their room. When they have isolation needs, but also when we have additional people that need to see the patient. And so by allowing us to have this virtual nurse in the room, other services can continue the work simultaneously so we can get our patients out. And so what we saw was a steep decrease in our discharge turnaround time by having a virtual nurse present while all the other work is happening, rather than putting that work on our bedside nurses. So we are really proud of our team because it was a learning curve for them, right? It was a trust, establishing trust with our discharge nurses, but we were able to achieve that. And then, honestly, the other thing that has really made a big difference is the monthly review of our metrics. So just like keeping that at the forefront, we're having our triads and our nurse managers present these at our executive meetings quarterly, and really asking them, what can we help you with? What are the barriers, right? And what we take back a lot of the time is, we need transportation, our transporters, to be, in line with some of these goals that we have. So we've incorporated that team into our discussions as well to see, is it a equipment issue? Is it, the utilization or the optimization of our teletracking services and access?
You just said so much there. I'm really glad
I know,
this
it's
is
a lot.
recorded because
I can keep talking.
because I've read all of the virtual nursing articles, and I always try to go to the virtual nursing sessions at conferences. And this has been a tough nut to crack, is the discharge turnaround time, because there are multiple variables in there when an order is written till the patient gets out the door, and some of them cannot be impacted by a virtual nurse. And so you've layered on top the discharge lounge and just like really attacked those issues from all angles. So this is well-earned 31% decrease in
Shout out to
turnaround time.
Maggie Sanfrantello out there, the ER director, who's really been a partner with us in our virtual journey.
Yeah. On the ED holding time, that also is very difficult to budge, especially with all the challenges that you have. And I think I heard you say there's some things about trust. Is there an example, or how did the virtual nurses, how do they build trust?
One, they're nurses that are coming from within, right? So I think, knowing that, Nurse Susie was working in that unit, a couple years ago, she understands the flow. We've taken our virtual nurses, and we've done kind of like, let's go and do an open house.
Yeah.
Show you where we are. Let's go to the units. Let's talk about, what are services we provide. We take feedback from them. We do a lot of surveys, and really just capturing from the staff what they need. So as I was mentioning, our patients sometimes need transportation, they need to pick up meds, they need to do all of these different things need to happen for us to be able to get them out and home. And so some of the feedback we took back from the managers and the staff was, I can't have someone go to the pharmacy and then bring back the meds and then go here and go there. Sometimes our patients are coming in and they're trauma patients. And so their belongings might be in our safe, belonging space. And so what we did was partner with transportation, allow for us to really look at how do we do multiple stops, right? We get the patient out, we go to, the safe security place, we pick up their meds, we do all of these things, and then we bring everything packaged up.
Yeah,
And
excellent.
so that was how we built trust with our staff.
Yeah. And so I'm sure people are thinking, well, how do you build trust when your virtual nurses are in Tennessee and you're in New Jersey? So I'm going to put you in the spot a little bit, Ramonita. At our symposium last fall, you talked about a bedside nurse who was pretty skeptical, and then she had an experience with a virtual nurse. Can you share that one, please?
Sure. So obviously, when you have nurses that are in Tennessee and you're in New Jersey and you don't see them, right? You don't know them, right? So the program's a little different. But we've had examples of things that the virtual nurse has picked up on, and now the bedside nurse feels relief. For example, we did have a patient that did not disclose that they were thinking of committing suicide, right, during their initial assessment. But when the virtual nurse actually did the full assessment, that nurse picked up on it and disclosed it, and we immediately put a sitter at the bedside. There have been other examples also where the nurses feel that having the virtual nurse allows them, frees them up, and therefore they're better able to connect at the human level with the patient, which is something that we know novice nurses struggle with, right? They're more into technology than the soft skills that we're trying to develop. Those are some examples. There's many others, but I think when things like that happen, it helps to build trust that someone with more experience is actually looking in, having the conversation with the patient, and then being able to communicate that to that primary care nurse.
Yeah. There's nothing like storytelling, to really kind of build trust as well. And in time and motion studies have shown, and nobody's going to be surprised at this, but a bedside nurse can get interrupted as many as 17 times during a discharge. So when the virtual nurse is not interrupted, they're able to build that kind of rapport where the patient might disclose their suicidal thoughts, where if you were, oh, excuse me, just a second, I got to answer this question, and back and forth, and you're not going to really feel heard and be able to share that.
So another example that I want to share is virtual nursing at Hackensack. We have 2 units that are sister units, same leader, 24 beds and 24 beds. So the nurses go back and forth, and now what we're finding is one of the units has virtual nursing, the other one does not. So now what we're finding is the nurses really want to work on the side where we have the virtual nurse because they feel that this experienced nurse is overseeing the care and they've developed that trust. So now that's the issue that we're up against, is that they only want to work on the one side versus the other side. We said, no, you were hired to do both. But, again, as we look to further develop, right, and virtual nursing, then that's another unit that we can take virtual nursing to.
That's a really nice control that you have set up there. And then, Brenda, still staying on LA General, thank you so much for taking the time to do a patient survey about this. And the sample size is kind of small on the screen, but it's almost 300 patients that you talked to. And they've really had positive feedback on it.
So as we were piloting and rolling out our virtual admission program, we initiated the program in one of our units that has about 350 admissions a month. So what we found was the bedside nurses were like, we need more virtual nurses. This time frame, we were giving them 12 hours of our peak times for admissions. And because it was a new process, we wanted to capture feedback from patients, right? How does it feel to be able to come in and now we have a virtual nurse doing your intake, asking you questions about social determinants of health. We're providing education on falls. We're providing education on infection control. Like, there are so many things that virtual admission nurse is doing while your primary nurse is looking at orders, reviewing, having conversations with the physician, tidying up all of the things, checking labs, getting all of that ready. So we did capture this information from our patients, and we did a short survey with them. First we did ask them, are you okay with having a virtual nurse provide you with admission intake and information? They said yes. And then with that, we took the opportunity to survey. I would say the majority of our patients absolutely enjoyed having a virtual nurse do their admission, spend that time to talk about falls, spend that time to talk about visiting hours, right? The very basic things that, to your point, sometimes get lost because we're busy, we're thinking about the labs that are going to be ordered, we're thinking about the next test, we're thinking about, our care plans and initiating those. And so this was a great opportunity for us to sell this to our staff, right? Like, this is really what our patients need, is that uninterrupted opportunity for them to share. And they may disclose there, right? And, they have food insecurities, they need additional support, they want to ensure we prevent falls and things like that.
I think that's awesome. And then moving to you, Amber, so you implemented AI on top of your virtual sitter program that you already had, and I think it was like you're 3 or 4 months in. So we've got fresh off the press your outcomes on alarm rates, which go to the bedside staff. So if you can explain for those who might not have it, what the stat alarm is and how that maybe the AI has impacted a decrease in your alarm rates.
Right. So the stat alarm is when that patient is moving and our staff know that alarm is a real alarm. There's really somebody looking at that patient. It's a real safety risk. And so with the AI program, the sitter was able, it'll flash yellow or red when the patient's actually moving. But at that yellow flash, that sitter is able to voice into the room earlier. And so it's helped to decrease the amount of stat alarms that they're having to use when.
To the bedside, yeah,
Yes.
and to the patient, because the patient hears the stat alarm
Yeah,
too.
yeah.
So,
The alarm is, you don't get it confused with any other alarm in the hospital.
yeah, when we do it on the exhibit floor, sometimes nurses just automatically come running. But-
You know,
And the research shows that if your response time is over 19 seconds, the falls on camera are more likely to occur. And I just have to say, Peterson's alarm rate, response time is 11 seconds.
yes.
So, and it's because
I can-
they know it's real.
Yes, they do know it's real, and I'll tell you one of the other secrets is we've cross-trained. All of my PCTs before they come off of orientation are cross-trained to work as a telesitter, so they move back and forth into those roles. So there's a trust between the staff that the person behind that is statting that alarm or voicing in is actually, it's an actual need for them to get to the room. So I think that's another reason why we have such good response rates.
Yeah, awesome. And since we mentioned everybody talking about Magnet.
We just found out we're going to have our first Magnet site visit. Excited about that.
And so at Hackensack, you are really far on in this journey across 4 of your hospitals and have been really carefully tracking your outcomes. So I want to take plenty of time to kind of walk through your throughput, your workforce, and your patient-focused outcomes here. So
Go for it. All right. It's a lot. When you start building a dashboard, there's a million things you can measure, right? But it's trying to figure out what brings the most value to the conversation. And indeed, this started with workforce, and it started with, sorry, Romany, I'm stealing the mic. Where we started was, obviously, it was about front-facing and patient care, right? Supporting our team. Where we were, we piloted at one hospital that built the case based on the outcomes that we were then able to make the argument that we should be able to scale to our other hospitals. And now it's a journey. These are pretty significant builds when you get into this to a team. Harmonizing models, understanding that we're going to work to one workflow and getting frontline buy-in to do that is really important for success. So now we have rolled out at these 4 hospitals, and what we have is we're looking back at our data. We started last winter. Our one hospital was already in place, and so we've squeezed the juice from looking at what we can do there. We squeezed that orange so that we can't get any more juice out of our baseline hospital. But now looking at the change in metrics at the 3 hospitals where we have expanded, we're really loving what we say. We're seeing units that really continued to have high turnover and had a lot of agency demand. Their numbers are dropping. And we normalize the data looking at the same high target time periods. If we look at our acuity in the summer and the winter, it looks very different in a couple of our hospitals. If we look at our staffing patterns, they look very different when you look at different points in the year. When do nurses graduate, or when do nurses choose to move on? We wanted to make sure our data was consistent, that we were looking at as apples to apples as best we could, which is why you see we're looking at from June when we went through to December to get that 7 months of good quality data for comparison. And the outcomes speak for themselves. Decrease in RN turnover, which translated into us not having the demand for our agency nurses. Now, when you get into quality and you're having a conversation with finance or your CNEs or wherever it may be, nothing happens in a vacuum, right? Like, you know, I have to be honest. Every hospital has a different fall reduction program going on, or a CLABSI reduction program, or a length of stay program. But when you start to look at your data across those campuses, and you start to look at, yes, we have these other programs in place, but how are you doing compared to other units that don't have virtual nursing? Like that's really the thing. So what we're seeing is that the metrics are stronger in these areas compared to their peer units and compared to their own baseline. That really tells the tale. So, you know, seeing that our length of stay, and length of stay really makes sense. Our model is really throughput driven, high admissions and discharges. The feedback from our team is there's confidence in the virtual nurse, because I mean it with no disrespect. Those nurses at the bedside, they're pulled constantly. The virtual nurse spends more time at the bedside doing the admission and the discharge than our bedside nurses do. They put the time in to build a really good, we're an Epic House, so an AVS, an after visit summary, and then present that to the patient and take them through it page by page, focusing on what's really relevant to that discharge information. And all these, you know, we're metric driven. We see the data coming out of the Avasure system, and we see the data from our own Epic that we track the virtual nurse, that I can see the amount of time they spend in minutes, hours, the amount of contact points they have, and the thoroughness of what they're doing every day. So there is transparency there. So what we see is, you know, obviously decrease in length of stay. We're discharging our patients home because the nurses are focusing on that care at the bedside. Are we getting people up? Are we keeping people mobile? Like that's what really matters. And then obviously take that forward. I was hoping for a little more decrease in falls, but I got falls with injury. So pretty happy about that. But again, having that front-facing time with patients, really important. And then obviously seeing the reduction in CLABSI and CAUTI, which we definitely link back to the amount of time a nurse can do what's right at the bedside. And then,
Something that I've noticed in the literature that's really emerging on the virtual nursing space is the crucial importance of the admission.
yes,
So I had always kind of assumed logically that if you want to decrease your length of stay, then just focus on discharges. But that's actually not true. The virtual nurse is getting up in front, and that all those quality indicators like the falls, and you already have virtual sitting, so you probably already had a good fall rate with that, but they're recognizing maybe which patients need a virtual sitter because they have that more thorough and getting started on those bundles and having the time for the quality.
Right.
And your metrics at Hackensack across the board, you have about 50-50 admissions to discharges with virtual nursing.
Yes.
And when we look at our other customers, it's really much heavier on the discharges. So I really think that is one of the crucial keys to impacting throughput, is making sure that the virtual nurse is doing the admission.
agreed.
Yeah. I sorry to interrupt you. Were you going to add in?
I just wanted to add something. So for Hackensack Medical Center, as I mentioned, 4LINK North and 4LINK South, which are two med-surg geriatric units, one side does virtual nursing, the other side does not. And when we look at our fall rate, when we look at our CLABSI rate, we are better, we're performing better on the unit that actually has virtual nursing. And it is because of the nursing assessment upon admission. That's what we're thinking, right? But our metrics in terms of our nurse-sensitive indicators have all improved with virtual nursing. And we have the data to support that. Yeah.
So on the maturity model, this is all great, but when you're going to your CFO, like, we want to scale now, or, you really have to, there's green here, but we need another kind of green on here. Like, where can we really put dollars to the savings? So thank you for taking the time to, like, really put kind of financial outcomes, because this is what we as nurses really need to do, as nurse leaders. Yeah.
And again, it's a skill. I work with the team. And we every day work with a lot of data analysts and help to support the program. When you go to scale, and there's just so many competing priorities in organizations right now looking for capital, and to make the case, it's hard. It's the times that we live in, really. But to go well prepared and to say, we can show you value, and then be able to back it up is what really matters. So, to your point, constantly looking at the data, constantly reevaluating and building your case. For anybody that works with finance, conservative. When we look in the literature, it's easy to say, when you do cost of falls, you can see this huge range of what people think for falls, or, what's your cost of a readmission. We go in with the most conservative number possible to make the most credible case to our finance team that we're not inflating the numbers. That there is that potential that to make these the most hard dollars we can related to cost savings with investment in a program like this. And honestly, when you sit down for the first time with them and they're skeptical, and then they see the outcomes, and then you build the outcomes over time, it does change the narrative, that it becomes a conversation about how can we invest, how can we scale, and what are our best targets for strategizing where this is going to be the most impactful in care.
So, and I think this is helpful for those that are planning, and thanks for sharing this information. So everybody says, and maybe both Brenda and you all can talk about, what is the virtual nurse to patient ratio? And so it's hard to do that. It's hard to answer that question. So this is like, I don't know, if you're in the planning phase, maybe take a screenshot of this, because it might help you, like, okay, that care unit has those many beds, and this is how much time a virtual nurse spends there. Brenda, do you have a ratio of virtual nurse to patients, or?
For our telecity?
No, for
Or
virtual nursing?
No,
Yeah,
we
okay.
don't really.
Okay.
I mean, what we found as we implemented these different projects was the learning curve, right? So initially, you're going to see that people are just taking longer to do the things, right? Like ask the questions, do the education, really familiarize themselves with where they're documenting. We also incorporated a handoff between the virtual nurse and the primary nurse to ensure that everything was covered if there were any concerns they had. And so initially we saw, probably about a 30 to 45 minutes. But as time went on, we started to see that decrease as they also felt much more comfortable with doing it, as the nurses
That's good.
began to
That's a good benchmark.
to
Yeah.
build the trust.
Yeah, okay. And what do you say when people ask you, like, how should I staff? Or,
So the model we defined in partnering with Equum was we want dedicated staff for each campus, with the ability that, like, if HUMC is surging but Ocean is kind of a little slow, it doesn't ever feel like that happens, but you have these times that we can pivot a nurse from one campus to support another. But we really do want that relationship, because it matters. It really matters. You want the bedside nurses to get to know the nurses that they're working with. That's where the trust comes from. So we do see it, that everybody at Equum, it's like, I'm primary Ocean, I'm primary Jersey Shore, JFK, or HMC, but they will move across those campuses to help one another. We also, while we staff 24/7, that slow period in the overnight is when they start building the known discharges for the next day.
Oh, okay.
And then in those evening hours is that peak admission and discharge. They scale up a little more in that
Yeah.
time period too.
Makes sense. Okay.
So that we can move across the campuses a little more fluidly to support where the demand is.
Yeah.
Yep.
And I just wanted to throw this up here too. It's pretty easy to get this from your from Epic anyways. So as you can kind of track, like, freeing up time for bedside nurses.
Yep. It's a direct, you see it. We added the virtual nurse, the time in Epic for the bedside RN dropped immediately. and that time and care was picked up by the virtual nurse. Now you can see in 2026, we continue, and again, we get better and better and better at this, right? We've also optimized, we've done some things in Epic related to macros
Excellent.
that are also decreasing our bedside RN amount of time in there too. So it's nice to see that you can see the difference between what's really impactful, adding the virtual nurse, and then the optimization with Epic 2 that we added later. Yeah.
So when you say we decrease turnover, this is your leading metric.
Yes.
You could say, nurses told us too much documentation.
Yep.
We've decreased their documentation, and then we've decreased turnover. So you've told us it's financial storytelling.
Correct.
So you've kind of followed that through, and you're getting attribution for this outcome to your intervention.
Yeah.
So
Can I mention one more thing?
Yes.
When your CNE is rounding, right, and she's talking to nurses, where we think about where this has been really impactful for us is, I look at my long length of stay units, and they're long length of stay for a reason. These are oncology patients, really clinically complex patients. Those nurses feel what they're doing every day, and it matters. They're building a meaningful connection with patient. They see the outcomes of what they're doing in care occurring over time. When you look at these high throughput units, it's harder for a nurse to fill her bucket. It really is. I mean, it's just they churn and they churn and they churn. The time they have to build a relationship and find a meaningful impact in what they bring in care every day is more challenging. So you see a lot of nurses leave for that reason. They move out of those high throughput units to other specialties or other areas. It's not about the pace of work. It's about the value they bring and how they feel in care, that it's meaningful, right? So from our CNE, it was very much as like, we need to make care as meaningful as possible. Change the environment, and the outcomes will come. So that was really part of our conversation about looking at these high turnover for nurses, high throughput for patient care. It seemed to be, for us, that's where our biggest impact could be. And now that we've done that, we are seeing that we have better staying power in the nurses on those units. It's not going to change them going to be an MP in 3 years, but it's going to keep them from moving out of the door at 12 months and a day to the next care setting. That's where we see it.
wow.
Yeah.
Just want to let that hit. That's powerful, and that fills our bucket as a
Right.
leader
Right.
to implement something that is going to really
Right.
impact the nurses. Yeah. Rem.
To your point, when I round and I'm talking to the frontline staff, they share their stories with me about virtual nursing and the impact that it's had on their life. And there are nurses that also float into those units when we have call-outs. And they say, Ramanita, is there a reason we don't have this on our unit? And I'm like, well, we're going to scale it eventually, but for now, this is where it's at. But I can tell you that in terms of traveler utilization, we were in the 300s during COVID. We had about that many travelers, if not more. And right now, we're in the teens. So we have been able to reduce traveler utilization. Right now, I have no traveler utilization in Med-Surg, which is great, right? That is awesome. That is awesome. And in terms of my vacancy rate, we're at 2.18% vacancy rate. Very proud of that. We've done a lot of work. I'm not saying it's just virtual nursing, but I'm saying all of these strategies help you to retain your staff. And at the end of the day, we want to retain our nurses, right? And we want to retain them in Med-Surg. We want to retain them at the bedside. And if eventually they become APNs, we're good with that. But we want to retain them, and we want to keep them engaged, because we know engaged staff have better outcomes than staff that are not engaged.
What did you say your vacancy rate is?
2.18% vacancy rate.
Wow. National average is, like, we were happy that it got under 10%.
We've done a lot of work in our entire system
Wow.
to retain our team.
So we want to make sure you all have enough time to get to your next session. It says 14 minutes here, but we're really supposed to end in a couple minutes. So Amber, do you have any kind of parting lessons learned or words of wisdom after your journey and where you're going next?
Well, I would say some of the great things that we've learned with our telesitter program is that it's not cookie cutter. It doesn't have to be just for falls. We use them for our seizure patients. That's some of our greatest catches is when we're able to catch when a seizure's occurring. We use them for our suicide risk patients. So there's all different kinds of things that you can do with those programs.
Yeah, thanks for thinking outside of the box. It's very innovative, and I hope your Magnet appraisers notice.
Thank you. We'll make sure we brag.
Any final words from you, Brenda?
No, we just, we know that we have a lot of work to do to support our nurses at the bedside, and I have learned a lot from Hackensack. I'm going to take some of this back for our teams, ensuring that we do support them in those spaces where we need, because ultimately it is for our patients. We want to expand our services, and so we continue to look at ways to help, whether it's our ER, whether it's our inpatient areas, considering how much time and energy it takes to do some of these things when the nurses can really be focused on other things. So thank you for coming.
Thank you all.